Let's turn to an effort born at Vanderbilt and developed by Dr. Gerald Hickson, the Patient Advocacy Reporting System, or PARS. Can you explain just what this program, which has been rolled out nationally, entails?
So PARS is a very interesting program and essentially utilizes spontaneous patient complaints that are voiced to the hospital or the institution's ombudsman, categorized into 5 different categories, and then utilized to generate with an algorithm a score. That physician can then be compared to his peers internally, to the entire institutional experience, and now to a national database that encompasses more than 40,000 physicians, 5,000 of whom are surgeons. And interestingly, those scores have a very interesting parabolic schema, if you will, as you track them. So the majority of physicians have minimal or no complaints. Then there's sort of a middle group, and then there are what we call the far outliers who have very high scores, and that correlates directly to risk of malpractice. And actually now we've correlated that score also to risk of adverse surgical events, and with certain specifically wound infection. So the PARS score is, if you will, almost a canary in the coal mine for concerns that may arise regarding care groups and even even individual physicians. We have curves that are specific or that are general for all physicians. We have specific subspecialty curves. There's actually a curve that exists for urology. And in general, the curves, all the interventionalists, that would be surgeons and proceduralists, have a displaced curve in that they tend to have more complaints than their non-proceduralist peers. But again, even within the proceduralists, there are differences in experience. So urology is sort of right in the middle of all the surgical subspecialties in terms of the degree of complaints. It's interesting, when you look at the types of complaints that we monitor, most of them relate to communication or access. And the old saw about availability, affability, and affordability that I think, Phil, you and I grew up with a long time ago, availability is critical. And again, another if you will, negative attribute of what's happening with the time crunch we're all under is physicians are less available. Patients are appreciating that, and in some cases it really impacts the patient's perception of the caregiver.
Well, just to kind of restate, PARS is based on limiting the disruptive and intimidating, at least initially, based on limiting the disruptive and intimidating behaviors that can foster medical errors, contribute to poor patient satisfaction, and preventable adverse outcomes. So do you think using PARS has improved quality at Vanderbilt?
We do think it has improved quality because, again, what we're able to do is help physicians document the behavioral issues and use those, as you said, in a stepwise process to refocus physicians on areas of concern. Again, what we found is that no one is specifically malicious, but what happens is things happen in people's lives, people react to them, and that can cause issues related to physician performance and interaction with their patients. And so common events such as divorce, personal or child sickness, other issues that can really impact the physician at work really then are reflected in these scores and are very helpful for us to identify people who may benefit from graded intervention. It's very interesting that we've recently had several physicians who, this is a national statement, not a local statement, were noted to have significant climbing in their scores, and also significant concerns were voiced about them by other team members, nurses, assistants, and those physicians actually had a cognitive decline associated with early dementia that wasn't picked up on any other basis. So
it's freaky. Okay. Well, the University of Pennsylvania is one of the places that subscribes to this, and there are many across the country, and it has resulted in a lot of controversy. So let me give you the physician take on this and just get your comment on it. It seems as if, anyway, that patient complaints about poor food in the hospital, wait times in the office, things that the physician doesn't really have control of, devolve down to the physician and get scored against him or her, and then this kicks off efforts to what you may say help the physician, but it seems almost to shame the physician and make them take the Dale Carnegie type courses and ultimately have them voluntarily leave the institution. And As I understand it, it's designed to limit the number of lawsuits by stopping behavior that's been associated with the higher risk of medical legal problems among caregivers. But the face validity of it seems low. Apparently the data speaks for itself and it is useful, or I assume we wouldn't be using it. What are your thoughts?
Well, I think there has been, ever since I began the practice of medicine in the 1980s, there has been this philosophy amongst physicians that they really didn't want to have external eyes looking at them. And if we go back to the old report cards that were proposed really in the late 1980s and 1990s, which were roundly and soundly removed from the scope of practice. But in reality, we've come back to that. And I guess, Phil, my retort to that is I certainly have had my share of complaints regarding poor food and other systems-based issues, but the system really does factor those out before it. You have attributable complaints and then you have system-based complaints. But sometimes when you talk about waiting time and lack of communication, and that gets back to the physician, and maybe the nurse didn't speak to the physician with a phone call or whatnot, that one of the other things we've seen about the PARS issue is not just individuals, it can be groups. So you can have sub areas within the hospital, micro environments, if you will, that are dysfunctional for whatever reason. So it also allows us to help those areas revert to a more standard level of practice and again function more towards a mean situation, if you will. The other aspect in the argument I would have against the face validity is we've actually shown marked improvement in patient satisfaction scores for those individuals who've gone through the program. The program largely is not the Dale Carnegie program. It's largely the 70% of physicians respond to the simple fact of self-awareness. They didn't perceive what their behavior was causing to the people around them. So self-awareness is a critical aspect of the success of this. And I want to make sure that it's understood that there's nothing pejorative about this. This is meant to be a positive aspect to help the physician change aspects of their practice that have been shown to be detrimental based upon their primary consumer, that being the patient.
Do you enjoy the quality work, and what would be the career path that this could take you on ultimately?
Yeah, I actually view this as a natural extension of, I think surgeons, specifically being the greatest advocate for their patients, really do enjoy being a part of a process that is much more uniform in terms of its outcomes. I mean, and one of the reasons I've become a big believer in creating bundles and creating algorithms is you do take a lot of the variability out of care, which has a direct then result in decreasing variability in outcomes. So I'm very, to me this has been a real sort of career awakening. As I've gotten older, I'm really looking at this as a significant aspect of what I do, and I would think that in the not too distant future for me, this will probably become a full-time endeavor for me. I'm still very active in urologic care. I still run a fellowship, and those things are very important to me, but you get to a time in your life when those things need to be passed on, and so this, for me, represents a very logical extension of what really I like doing, which is interacting with my peers.
Is this an avenue worth pursuing to enhance a career for the young urologist, and how should they get into it?
Yeah, I think this is an absolute area. As a matter of fact, we've been asked by the American Urological Association to have a course specifically about this next year at the meeting, and that's already been submitted. Very excited about that, and I'm really in the process of trying to mentor not only young surgeons, but specifically young urologists in this area, because this is going to be absolutely a part of our physician experience, for the foreseeable future.
Great. Well, thank you.